Welcome back. So now we are going to start the last lecture of this school, which is going to be taken by none other than Professor Narsingh Verma sir. We all know him, but for outside students, I would like to tell them that he is head of the Department of Physiology, King George Medical University, Lucknow, and General Secretary of our society, Indian Society of Chronomedicine. So I request sir to please come and take over the lecture.
Maintained, and you know almost everything, that central clock, peripheral clock, everything. So what I will do, I will try to correlate these chronobiological principles with modern day-to-day medicine. So it is not possible to discuss everything in the medicine, but I will try to correlate only by giving one example, and that is the blood pressure variability, which is very common when we talk about variability. It is very, very common. So this you all know that the human circadian time structure, and you know that every physiological mechanism or process has its own time rhythm, and according to that it goes up and goes down. So we know that every mechanism, because every peripheral clock is being controlled by the central clock, so all the mechanisms, whatever have been learned so far, we have been able to demonstrate the particular rhythm. Even the bacteria which are present in our intestine, they do have a rhythm, and they also regulate our own rhythm. This is known. Only because of that, we know that our biome, which is present inside the intestine, is also very important. We all know that when a baby is born, hardly any bacteria is present in the intestine. But in adult, around 1 kg bacteria lies only in the colon. So they also regulate and affect our own circadian rhythm. So coming back to the whole scenario, if you see the day-to-day, this is a very beautiful picture by Michael Solowski. He's a very, you can say, great person in the chronobiology. I am fortunate, I have met him twice, and once he invited me to come to his laboratory, but because of my own constraints, I was not able to go there. So he has given this beautiful picture that all symptoms which we encounter day to day in our busy clinical practice, the symptoms have a particular time. See, the gout attacks are more at this particular time, and gallbladder attacks again a particular time. GERD and peptic ulcer attacks early in the morning. The congestive heart failure again between the 3 a.m. and cluster and migraine headaches more in the morning, and the asthma attacks again in the morning. You see, all death occur mostly in the morning. You see, if you find out all death time, you will find that they are more in the morning hours. And the allergic rhinitis, cold, flu, again after 6 a.m., 7 a.m. This time they are more common. And rheumatoid arthritis, again in the morning hours. Depression is worst in the morning hours. Similarly, again, the other factors like the menopausal heart flushes, restless leg syndrome, they are more during the night time. So every symptom has its own rhythm. We can utilize this knowledge in our history taking. And only by history taking, I will give one example. The rheumatoid arthritis is more in the morning, osteoarthritis more in the evening. So just by history, we can point out that our patient is suffering from this disease. May not be perfectly right, but we can minimize the number of differential diagnoses by taking help out of this picture. So coming back to our own blood pressure variability, blood pressure keep on varying, and I will tell you that it varies from pulse to pulse, and not only that, it also varies during the every minute, every hour, and on the basis of that, we classify that those persons who do not have this variability, they are called as non-dippers, and those who have this variability, they are labeled as dippers, and those who do not have those who have the reverse dipping pattern, that dipping occurs during daytime, not during the night time, and even the dipping may be more, and when it is more, it is called an extreme dipping pattern. So dippers, non-dippers, extreme dippers, reverse dippers, these are the various type of person we can have. And this can be known easily by applying the ambulatory blood pressure monitoring. And in our department, we have this facility, and you can very well utilize that facility to find out whether the person has a dipping pattern or not dipping pattern. In the coming slides, I will show you the blood pressure also varies according to various responses, like physical activity, the emotions, and the posture that we taught to our students, and the respiratory cycle. With each respiratory cycle, blood pressure during inspiration and expiration, it is entirely different. Time of day, we know it keeps on varying. The food ingestion, even after food ingestion, blood pressure is different. And salt intake, how much salt we have taken, and caffeine intake, use of nicotine and other alcohol and other stimulants of cardiac system. The sleep deprivation, which you learned earlier by other speakers, and the seasonal variation is also there. This is very important to my country because in India, every month has a different season. So our patients who are receiving 2 drugs, 3 drugs for hypertension during winters may require only 2 drugs or 1 drug in extreme summers of May and June. This is very important. And high altitude do have change in the blood pressure. Similarly, the blood pressure keeps on varying by simple activities. For example, a psychological stress and meetings and even the public speaking, the blood pressure can change the tune of 20 to 60 millimeter of mercury. 20 to 60 millimeter of mercury in systolic pressure. And similarly, anger, conflict, again 20 to 60 millimeter of mercury. So these emotions and these changes, which are very physiological in nature, they can change blood pressure to the tune of 20 to 60 millimeter of mercury, and they include the anger, the sexual intercourse, major physical exertion, running, lifting again, and pain. Why this is important? Because most of the time in our busy clinical schedule, patients come to us and say, "Doc, my blood pressure is very high." So I say, I don't believe unless I do myself. And important thing is that he might have taken blood pressure in a pain or having after a particular activity. So what had to be done before labeling anybody hypertensive? We must do either ABPM or home monitoring. By home monitoring, 2 readings in the morning, 2 readings in the evening for 7 days. Why 7 days? Because we know Sunday is not Tuesday and Wednesday is not Friday. Every day the schedule is different. When schedule is different, then the blood pressure will be different. So a single reading of blood pressure has no meaning, and we call in our language it is casual BP. Casual BP cannot be taken as a marker for the diagnosis. So similarly, waking from sleep, again the blood pressure rises. The person has just waken out of sleep, and if the blood pressure is measured, it will be high. So we advise half an hour after waking up and before taking tea and when the bladder has been evacuated, so that we can find out the correct blood pressure. And not only that, driving, mid-morning surge, they are there, 20 to 40 millimeter mercury, 10 to 20 millimeter mercury driving. Posture, we know very well, posture is being taught to undergraduates. Then the anticipation of major physical exertion. No physical exertion, only anticipation. Only anticipation will rise blood pressure. And the ambient temperature and the eating will increase blood pressure. And the smoking, definitely tobacco use will increase blood pressure. Telephonic call, person is taking call and other person is taking his blood pressure. No, blood pressure will definitely rise. And the distended bladder can make a change of 10 millimeter of mercury. So these minor things have to be taken into account. So the blood pressure variability, how you can utilize this knowledge in your day-to-day practice to have more accurate readings and you can cure your patients well. Then the other things which I have already talked about, chronic, the psychological stress. Climate season can have the change in blood pressure in the tune of plus minus 10 to 20 millimeter of mercury. Either it is more during the winters or it is less during the summers. And the increased alcohol intake, again, if you remember, it was being taught sometime that alcohol in little quantity can be helpful for cardiovascular system, but the latest guidelines from WHO have suggested that alcohol in any form is not good. So increased alcohol intake can change blood pressure to the tune of 10 millimeter mercury. Shift work, even shift work can increase blood pressure to the tune of 10 millimeter mercury. We are talking about systolic blood pressure. And the DASH diet can reduce salt intake, can reduce in the tune of 5 to 10 millimeter mercury. So these are the factors which are responsible for blood pressure variability in day-to-day measurement. Then you very well know that acute changes in blood pressure are mediated by baroreflex activity. And the baroreflex failure can make out changes in the blood pressure and they can become more pronounced or less pronounced, and the blood pressure maintenance is affected by the baroreceptor failure, and that reflex failure can have our post-synaptic changes, and we can very well assume that this can happen. Even the selective baroreceptor failure can be there at the various points. It may be calmness, arousal. These factors do have the selective baroreceptor failure or non-selective baroreceptor failure that can be there. Then the blood pressure variability, there are mechanisms why the blood pressure variability is there and what is the clinical relevance. Blood pressure variability is the physiological characteristic of the cardiovascular system. It is very well physiological, it is not pathological, but when it becomes extreme, then definitely it can create a burden on the cardiovascular system. So these are the mechanism and clinical relevance. If you talk about relative risk reduction of fatal events and combined fatal and non-fatal events in patients on active antihypertensive treatment versus placebo and no treatment, you will find that lot of changes, lot of things you can find out by systolic diastolic hypertension, isolated systolic hypertension, and mortality, all-cause mortality, cardiovascular, non-cardiovascular, fatal and non-fatal events, they all can be corrected by using the drugs and making blood pressure to change less. And within the individual, blood pressure variability over time varies from one patient to another patient. You can see here the patient with lower blood pressure variability, here the blood pressure variability is very low, and it can be very high blood pressure variability in another patient. So this can happen. So why it is there, rather than representing a background noise or a phenomenon occurring at random, these variations are known to be the result of complex interaction between extrinsic environmental and behavioral factors and intrinsic cardiovascular regulatory mechanism. So either extrinsic mechanism is involved or intrinsic mechanism in the form of neural control, neural reflex, and humoral influences are responsible for these changes in blood pressure. And it is not that all have been understood. Some of them are still not clear why at all it is occurring. So there can be different types of blood pressure variability. Short-term blood pressure variability within 24 hours, that can be short beat-to-beat variability. Every beat will have different blood pressure. We know by using NIBP, we are doing this in our laboratories, and animals basically, and short within a 24-hour period, minute to minute, hour to hour, blood pressure keep on varying, and day to day, day to night. So variability can be very short, or it can be long-term variability in the form of day to day. And I told you the example of 7 days from Monday to Sunday. That is why when I do ABPM, I do it for 7 days. And 7-day ABPM is very difficult to do. But thanks to our Indian patients, it is very clear that if we order our patient to wear this ABPM for 1 month, they can do that. They are very obedient one. That depends if you have explained them properly that it is going to help them, then definitely they will wear it for 1 month, what we talk about 7 days. And most of my colleagues in India, they are doing ABPM only for 24 hours. Here I differ from them because I believe that if they are doing it for 24 hours, then the white coat effect is not felt. And what we get result in first 24 hours is not good. If we do it for 7 days, then only the complete knowledge can be acquired. So long-term variability can be day to day, visit to visit. Every visit, the patient will have a different blood pressure, and seasonal, which I had talked about. So mechanisms, what are the mechanisms, possible mechanisms? Short-term variability, beat to beat, is basically driven by baroreceptor activity, which I showed you that baroreceptor reflex activity is different in different individuals at different time. So every beat have a different baroreceptor background, and because of that, the blood pressure variability will be there. Respiration is main cause of physiological variation. We know that even heart rate varies with respiration, and inspiration and expiration cannot have same blood pressure. And sleep is one which again varies both in short-term and long-term. The chemoreceptors are also responsible for the short-term variability what we have. Mechanism can be central and reflex autonomic modulation. During these activities, that autonomic modulation is responsible for this short-term variability, and reduced arterial compliance is also responsible for this variability. Humoral effects of various hormones and rheological factors because of the vessel wall, and emotional factors because of other hormones, and behavioral influences, physical activity, and postural changes may be responsible for this short-term variability. Mechanisms for the long-term variability have not been understood properly, and day to day, maybe because of behavioral, we can explain them, but visit to visit again, maybe behavioral one, but seasonal, we know it have been reported to be lower during summers and higher during winters, and inappropriate down dosing of drugs lead to increase in nighttime BP with hot weather reported in some studies. So we have to change our medication according to season, and mechanism here are not well studied. Behavioral factors have been found responsible for that, and increased arterial stiffness is one factor which is said to be because that this long-term variability may be there, and even poor BP control may be responsible for visit to visit blood pressure variability, And inconsistent office reading is again a cause, because in office reading, which was very prevalent in my country, now they are accepting the home monitoring and the ABPM. So it is a known and natural characteristic of blood pressure, a physiological phenomena, but it may be secondary to mechanism of varied nature and divided into short-term and long-term. We have studied that, and we know that different prognostic impact of nocturnal BP fall and short-term blood pressure variability. If this night dipping is there during night time, you can see this dipping. This is daytime and night time, and here is no dipping. So it has been seen that no dipping is damaging for the arterial wall, and not only arterial, because it may produce endothelial dysfunction, and that may lead to hypertension as well. So we know that 24-hour intra-arterial BP, if it is not changing and during night time not going down, it may be damaging for our various cells. So various indices are used to assess this blood pressure variability. How we can assess the blood pressure variability? We can assess by using the standard deviation and the day-night BP changes and the residual BP variability, trough to peak ratio, night to day ratio. These are indices which we use by doing ABPM. Then we can find out the blood pressure variability there, how much variability is there. Continuous beat-to-beat BP recording can be done, and that standard deviation can be a good indices, and repeated readings are required. 24-hour ABPM, again we can use these indices. So all these indices tell us how the blood pressure is changing, and by that we can read out and find out, define the blood pressure variability variable. The smoothness index is used to assess the amplitude and distribution over time of blood pressure reduction by treatment. 24-hourly BP changes and standard deviation. So smoothness index can also be used, double amplitude can be used. I will tell you about that when I discuss the report. So residual blood pressure variability is the fast fluctuation that remain after exclusion of the slower components of the 24-hour profile through spectral analysis. Like the spectral analysis of heart rate, we can do spectral analysis of blood pressure, and by that we can find out residual blood pressure variability, which is more prognostic. And day to night dipping status and night to day morning surge can also give us an idea about what changes are occurring in blood pressure variability. Circadian variability can be same thing. So again here, night to day variability, morning surge, they can be important. And the nocturnal dipping status, which I said in the beginning, the mechanism underlying non-dipping status, why the person may be non-dipping, maybe because of the persistence of sympathetic drive at night and reduced sensibility of baroreceptors at night. They may be responsible for dipping pattern. And when the dipping pattern is not there, non-dipping, maybe because of the sympathetic drive which is present during daytime, is persisting during night time. That can help us to decide whether we have to produce a pharmacological dipping. In one study, which is not, I'm not presenting here, I presented in Chronobiology, which held at Turkey, at Antalya. And in that study from my lab only, it shows that those patients of diabetes who were not having hypertension, but they were non-dipping. So what I did, their blood pressure was in the range of 120/80. They were diabetics, but they were having albuminuria. So what I did, they were non-dipping pattern. What I did that just I added 2.5 milligram of Remipil in the evening. Why 2.5 milligram? So that they do not go into hypotension. Only 2.5 milligram of Remipil was enough to produce dipping pattern during night time. That I call as pharmacological dipping. And this pharmacological dipping was able to reduce albuminuria in these patients. So that was a study I presented as Chronobiology in Antalya way back, I think in 2006. So it is possible. The pharmacological dipping is possible, and we have several data which show that pharmacological dipping can be attained. But only thing is that you have to be very cautious that patient is not going into hypertension. Because we know when blood pressure is very low, then some patient will have some neurons, some cardiomyocytes will be affected, and they can be damaging for that particular organ as well. You can stop me in between if you want to ask anything or interrupt anything or have any query in your mind. I have enough time to discuss all this. There is no hurry. So you can stop me in between, because it is not a unilateral lecture. We want to discuss something, and if you can stop me anywhere in between. So the non-dipping pattern may be because of the persistence of sympathetic drive at night, which I told, which is very, very common. And here, the common feeling is that when the sympathetic drive is more during night time, we must give a beta blocker. But more studies have shown that even ACE inhibitors or ARBs will reduce sympathetic drive during night time. Not necessarily that we should give beta blockers. Reduced sensibility of baroreceptors at night, that can be one reason. Baroreceptors, which their sensitivity go down during night time, and because of that, the non-dipping pattern is there. Volume overload in specific conditions during night time. That is possible, we know, especially in those patients who have different type of heart failures. Autonomic dysfunction, the most common cause of non-dipping pattern. And this autonomic dysfunction, again, if I say it is the most common cause, then probably diabetes is one condition where we have a lot of autonomic dysfunction. So you can say that diabetes per se have less dipping pattern or no dipping pattern. That I will show some slides which we have done in our lab. Nocturnal dipping status, non-dipping status associated with CV risk. Why we are bothered about this dipping pattern? Because we know that non-dipping pattern have high CV risk. And that is more true for our population, Indian population. It is known that they are more prone to develop all these complications if the dipping pattern is not there.
So how much dipping should be there?
Yes, that's a very good question. What is dipping? If the nighttime blood pressure is less than daytime blood pressure, the tune of more than 10 millimeter of mercury, then it is called as dipping. If it is less than that, it is non-dipping. Some change will definitely occur. But the most important thing here is, which is not written anywhere. Normally we think that dipping should occur midnight. But today what is happening? No one is going to bed at 12 or 11 at midnight. So the dipping may be delayed. Dipping may be delayed because it will depend upon going to bed. It is not dependent only on time. It is also dependent upon the physical activity, our activity, at what time we are going to bed. So that had to be kept in mind. But more than 10 millimeter mercury change during night time is called as dipping pattern.
So 10 millimeters is systolic?
Systolic. Systolic.
Sir, what about extreme dippers?
What about?
Extreme dipper.
Extreme dippers is also there. They have dipping more than 20 millimeter of mercury. The extreme dipping pattern is not good, because when the blood pressure goes down up to that level, then some neurons are affected and some cardiomyocytes are affected. Some nephrons are affected. So extreme dipping pattern is again not good. Extreme dipping is associated with higher risk of cerebral and retinal ischemia. What you ask, it is written there. that extreme pattern of dipping may have harmful impact on nephrons and neurons, because these are two very sensitive tissues about oxygen. And when, yeah.
Sir, in case of night shift worker, this will be present or not?
That will depend whether the night shift workers are actually night shift workers. Why I am saying that? We doctors do night duty, but their night duty is they are lying in the bed.
In case of like security guard.
Yes, their dipping is not seen, because dipping is basically has multiple factors, but basically because of our posture. So you are very correct that those persons who are having physical activity during night time, they will not have that typically. But when they sleep during daytime, the dipping is not seen. But this is an area where we need more research, whether they have same dipping pattern during daytime. And the area what Dr. Bhardwaj is talking about, one can have a good study that whether those who are doing shift work and they are having sleep during daytime, so whether they have dipping during daytime. Some data we have, one study you can find out on ResearchGate, Anjum B et al. She had done this ABPM in shift workers, especially nurses. But they were nurses, not necessarily they were physically active during night time. But some idea you can get by that.
I have a protective mechanism.
Yeah, it is protective mechanism. It is protective mechanism. Because when a person is lying down, you know the heart and brain is on the same level. Heart need not to pump blood very high. And this dipping has not been seen in dogs and those animals who have 4 legs.
Sir, always protective.
It is very difficult to say. Very difficult to say. But basically, all these are protective mechanisms. Even fever is protective. Even pain is protective. We teach in physiology. All physiological mechanisms are protective basically.
Sir, is dipping related to the fall in the lower body temperature?
It is not because of that. It is also associated with that. Yes, core body temperature do change during night time. But I said that mechanisms are not very clear. What we know are the factors which we know.
So in case of non-dip also, only when the symptoms arise of cardiovascular and other, then only they came to know that they have non-dipping blood pressure. Otherwise,
Symptoms are very, very late. We cannot wait for symptoms. That is why I say those individuals who have high risk, they should be submitted to ABPM or home monthly.
Sir,
What are these high risk? High risk can be various types. May have family history of hypertension, family history of diabetes, family history of cardiovascular disease, family history of CAD, and overweight, particular occupation. So these all are high risk individuals. They have to be subjected at least once in life for ABPM.
Sir, one more. During the ABPM monitoring for 7 days, and there will be, after the data has been collected and we find that there are some outliers in that data. So during ABPM monitoring, can we request patient to have some diary with him to note down his activity schedule?
When 7-day ABPM is done, it is always done with diary. We give a diary to patient and they note down what they were doing at particular time. And you have asked the relevant question. When I presented these data in one of the conference of home monitoring of blood pressure, Professor Anuj was also there, and I said, just to make persons more concentrated, I say that when I did my ABPM and when I was taking a lecture of MBBS, and those days Kalam Center was not there. Old lecture theatre you still know. And in that even the mic was not there. And the 185 students, fans, all fans were very noisy. So I had to work very hard, almost shouting. So at that time, my blood pressure was 190 by 110. When I said this, then all persons sitting across, they said, okay, sir, please do some, give it some lower value. 180, 110 is too much. I said, no, it was 180, 110. Still, I'm not hypertensive. That's what I said in the beginning. You might have seen 20 to 60 millimeter mercury change can occur when a public speech is being delivered. 20 to 60 millimeter mercury. Still, a person is not hypertensive. This hypertension is referred as episodic hypertension. It is related with a particular episode.
Sir,
Yes.
What is the incidence of hypertension in driver? Because as you have mentioned, the driving can rise the BP by 10.
Again, area of research. We don't have any data. But I feel that drivers will definitely have more hypertension in relation to other population, especially Indian drivers. Because in Western countries, you just have to sit on your seat. Everything is being done automatically. And they need not to bother about anything. And here, you are not very sure what is happening, going to happen in 1 minute. So driver must be having more hypertension. I don't know, because I don't have any data. But this is one area one have to do. Yes.
सर आपने वो एक स्टेटमेंट दिया था कि जिसमें नॉन डिपर का डैटिक और माइनर लेवल में दिया था, तो वहाँ आपने डायनेमिक 2.5 ऐड किया है. तो व्हाट वाज द रीजन टू ऐड दिस?
Actually, I wanted, yeah, very good. I wanted to have two effects. You know that Ranipil is a drug which should be given to even non-hypertensive. It is good for the diabetics as well. And I wanted to have the nocturnal dipping. So it was given in the evening purposefully so that we can achieve the nighttime dipping pattern. Why Ranipil? You should have asked why Ranipil. It is a weak agent, having more vascular effect rather than antihypertensive effect.
Minor albuminuria.
Because minor albuminuria was the first sign. It is first sign of any cardiovascular risk or renal risk. It is the only sign which is included in both cardiovascular as well as renal.
Diabetes की जगह CCP जो नॉन हमारा यूज किया जाता है.
We have data of the Ranipil, but we don't have data with CCB. CCBs are long acting and they can produce hypertension. And we don't have that robust data with CCB. That is why our preference of choice of drug for diabetes is ACE inhibitor, not CCB.
Sir, one more thing. There is a huge challenge of dealing with seasonal variation, temperature regulation, especially in North Indian patient here. The doses get reduced up to 1/4
Yes.
from the winter to summer season, and in just routine clinics we have just only one monitoring in the just office measurement. So how can we manage this in a better way? The patient will not suffer from both hypotension and hypertension.
You can advise to your patients that before Holi, they must do 7-day home monitoring, and again before Dasera, they again do 7-day home monitoring. Two major variations occur in our country. And other places, we can follow same. The month which is having major changes, you can order, you can advise them to have 7-day home monitoring. I have seen that those patients who were receiving 3 drugs combination for hypertension, during May, April or May, we have to reduce at least 1 drug. Only 2 drugs are enough. And those who were having single drug during summer days, we have to add 1 or 2 drugs more during November and December.
So Professor Verma, I have one query. So
Yes, sir.
This dipping happens in the normal blood pressure subjects only, or low or high blood pressure subjects also show the similar pattern of dipping?
Yes, sir. Sir, normally those who are normotensive do have this dipping pattern.
Okay.
Non-dipping is bad. Dipping is not bad.
Okay.
But hypertensive may have different dipping pattern depending
Compared
upon
to
the
the
drugs
normal.
used.
Yeah.
So it is very important to know dipping pattern, because this will give you idea if you are using 2 drugs, 1 drug should be given in the morning, 1 in the evening, to avoid excessive dipping during night time.
So dipping pattern itself has lots of clinical implementation,
Yeah.
it seems from the discussion.
It is protective. It has to be there. Non-dipping is a bad thing.
Okay.
Dipping is good. But excessive dipping is bad, and reverse dipping is very, very bad. Reverse dipping we see in renal patients.
In which patients?
Renal patients,
Okay, renal.
those who have secondary hypertension, or those who have autonomic dysfunction. Reverse dipping pattern. During daytime, the dipping is there. During night time, BP is more. During daytime, it is less. Reverse dipping. It has been seen in chronic renal failure patients.
Sir, one more thing. After doing ABPM and we got that there is a high blood pressure variability in that patient, so we can also go for cardiac autonomic testing like HRV and other tests.
They are the battery of tests that should be done in all diabetic patients. Because all diabetic patients at the time of diagnosis, they have 60 to 70% of them have autonomic neuropathy. Because neuropathy is the most important, earliest complication of diabetes. So, extreme dipping, I talked about. Chronotherapy here, I have already mentioned that we can select drug according to dipping status. Morning surge, we know morning surge is double-edged sword. Morning surge is not bad. Nature has produced this morning surge purposefully, because I told you that we human beings our heart had to pump blood to brain, which is above to heart. No other animal had to do that. Those four-legged animals, their heart and brain is on the same level. So, when a person is lying supine, and when he rises from supine position, then definitely the blood pressure had to change. So, that morning surge is just preparation of the body for the daytime postural change which is going to occur. It is preparation of body. The body knows that after 1 hour, the person has to rise, and we have to prepare for more powerful contraction of the heart, and we have to increase systolic pressure so that we can maintain the circulation all over the cells. So to prepare that, the body secretes various hormones. Melatonin goes down, cortisol increases, and because of that, the morning surge occurs. This morning surge is very, very important, but excessive morning surge produces a lot of diseases. You know, most of the cardiovascular diseases occur during the morning surge time, and most of the strokes occur during morning time, just because of the changes which are occurring in the morning surge. So it is double-edged sword. If the morning surge is compromised, again the person can develop postural hypertension and other problems. If the morning surge is more, he will develop various diseases. So no consensus on the definition and threshold value of pathological MBPS, morning time blood pressure surge. We still do not know how much surge is beneficial and how much becomes pathological. We don't know, because it is so personalized. We still do not know that who should have 120/80 millimeter of mercury blood pressure and who should have 100/70 blood pressure, because it is highly personal. No blood pressure value is good or bad. It is highly dependent upon the person to person, varying person to person. Usually assessed using the ambulatory blood pressure monitoring. When you do MBPM, then only you can find out morning surge at what time it is occurring and up to what value it is occurring. Exaggerated surge is associated with target organ damage. If the morning surge is more, target organ damage has been seen, reported, and leads to increased risk of cardiovascular events or death. So that's what we know. If the morning surge is more, the target organ damage is more. Again, an area of research for the physiologist, medicine people, to measure the morning surge, correlate it with these other diseases. That can be good research for MD thesis or other. Weekly and seasonal variation in MBPS augmented on Mondays and in winter. It has been seen that morning surge is more during winters and morning surge is more on Monday in comparison to Saturday. This is again important. So probably it is more behavioral. Mondays, and mostly these data are Western data. Their Sunday, the real Sunday, everything off. And in Indian, Sunday is more dangerous. They have more work on Sunday. So probably the same thing cannot be true for ourselves. But we don't have our data. We have to rely upon the data produced by themselves. So this is again an area of research. Those who are engaged in doing research on ABPM, they can do the morning surge variation during weekdays. And when we call weekday, rest day should be taken as rest day, not Sunday. Weekly and seasonal variation in morning blood pressure surge augmented on Monday, and MBPS increases with age. As the person becomes old, morning surge is more. So it has some relationship with blood vessels. And hypertension. In hypertension, the morning surge is more. So in comparison to those who are not having hypertension and those who are having hypertension, morning surge is more in hypertension individuals. Glucose intolerance, again area of research. One can do morning surge in diabetics, pre-diabetics, and diabetes having 10-year duration. Again area of research. So my job here is to, you have learned everything on the chronobiological principles, and learned speakers have done everything. I wanted to induce some research of Indian origin by you all people. You can make a lot of research processes on this, and that is what I'm suggesting. Inflammation. It is related with inflammation. You can correlate morning surge with various inflammatory markers. I'm suggesting MD thesis. Those who are professors, they can advise their students to do MD thesis on inflammation and morning surge. Do 24-hour ABPM and have inflammatory markers, TNF-alpha, interleukins, CRP, HSCRP, and then see what relationship is there. And alcohol, smoking, stress, etc. A lot of factors. And you can watch out the relationship between these factors and morning surge. So morning surge, I feel behavioral changes. You can see here, patient A having almost 1, 2, 3, 4, 5, 6, 7 readings, and you see here that it has good dipping pattern. Patient B, the hypertensive, is still having the dipping pattern, and patient C, you can see here that all readings are not same. There is no synchrony. And here the increase, you can see that trigger and risk, that is these outlying readings you can see here, they are a risk for the particular person. And you can very well understand these things, that this is the daytime BP, awake, evening blood pressure, and you see that normally there are two troughs, two peaks in all individuals, healthy individuals of blood pressure. Two troughs, two peaks. One peak early in the morning, second peak in the evening, two troughs, one trough in the, say, midnight, and second trough during midday. So you can see here the person is awake, evening BP is this, and he got into sleep, and you can see that lowest BP is during sleep, then pre-awake BP start rising, and the morning BP after 2 hours of awakening BP is again rise. Because demand is not standing, supine. You can see still person is supine, still blood pressure is rising. Because the body knows that after 1 hour he has to become erect. So body is preparing for that, and it is because of the hormonal effect. Cortisol, melatonin, these two we know, and plenty of other hormones. Their interaction is producing all this. So what is important? Sleep through surge. This is sleep through surge. Number one, this one. And pre-waking surge, BP is rising. And the rising BP surge, third one, 1 or 2 hours after rising. And the difference and these parameters can help you to find out individual parameters, and you can correlate very well them to various target organ damage. These are the data which show that 24-hour BP variability has clinical relevance. I'm not talking in my own way. We have good number of data. I have collected some of them. We have still more because it's showing only up to 2010. We have more data after that. And the person who has done the maximum research on this is, his name is here, I'm not sure. Not Parati, the person from Spain. I will tell you. So you can see here the cross-sectional, longitudinal, all type of studies are there, and only one on rat, others are human. They have shown that the 24-hour blood pressure variability has been found related with target organ damage, cardiac renal damage, carotid intima media thickness, the cardiovascular events, death and stroke, CV events. So you can see that very well correlation is there. And lot of individuals have done research and it established fact. And relationship between 24-hour BP variability and organ damage again has been well studied. And here you can find, I was talking about Hermida, R. Hermida. He has done maximum research. You can find more than 300 papers on blood pressure variability, ABPM by R. Hermida. So 24-hour mean has been found related, and mean arterial pressure, systolic blood pressure, 24-hour systolic blood pressure ST, and the mean arterial pressure ST, and they have been found related with target organ damage as well as carotid intermedia thickness. So, and the relation between the risk of stroke and morning BP surge was well established in Osama study that proved that it is related with that, and it was found related with the stroke total and also related with the ischemic stroke, but more with the hemorrhagic stroke. So hemorrhagic stroke was more related with the morning surge rather than the ischemic stroke, but stroke as a whole was found related with the morning surge. Here again, the prognostic value of ABPM and home blood pressure monitoring compared with office blood pressure in the general population. Published in Circulation, it showed that office blood pressure measurement failed to do justice. Home monitoring, you can very well see here, office is this one, and home monitoring is this one, and 24-hour ABPM is this, and daytime versus nighttime BP. So you see that nighttime BP was more related to these changes rather than blood pressure during daytime. So it gives us idea that probably those patients who have high risk, we have to go for home monitoring or ABPM. And if it is not possible to do ABPM, then probably in comparison to daytime, nighttime BP is more important. We should aim for nighttime BP rather than daytime BP if we want to find out target organ damage. Long-term blood pressure variability. And here, this slide is good, and Parati has made it extensively good. And it shows that very short-term blood pressure variability, beat to beat. it is mainly dependent on ventilation. Ventilation. And here the central sympathetic drive is more, and arterial or cardiopulmonary reflex, humoral, rheological, behavioral, emotional factors, activity or sleep is less, and because of that, the very short-term blood pressure variability beat to beat is important. And here it has been found related more with subclinical organ damage, beat to beat variability. And the cardiovascular events have been found more related with the beat to beat variability, and the renal outcomes were found related to that, but it's still question mark. We have both type of results, but no doubt about subclinical organ damage and cardiovascular events were found related to beat variability. Again, short-term blood pressure variability over 24 hours, it is basically because of change in arterial compliance and inappropriate dosing or titration. Dosing of drugs is not complete. And here, the short-term blood pressure variability has been found again related with subclinical organ damage, cardiovascular events, cardiovascular mortality, all-cause mortality. So short-term blood pressure variability is more important when we want to predict the organ damage. So we should go for ABPM in all those patients who are having high risk. Mid-term blood pressure variability day to day, one day to another day. Subclinical organ damage, cardiovascular event, cardiovascular mortality. So we have very good relationship with all these risk factors. Then long-term blood pressure variability, seasonal changes, and adherence to treatment and BP measurement errors all are there, and it has been found to be more correlated with subclinical organ damage, cardiovascular events, all-cause mortality. So a very good correlation has been shown here, and you can find out and study the whole review in the Nature Reviews of Cardiology in 2013. This shows that the importance how we can predict by using these parameters the faith of the patient.
Sir,
Yeah.
sir, any correlation with endothelial function which is blood pressure variability?
Endothelial functions, we have some data which show that endothelial functions are first to change. But it is very generalized. That is why it has not been included. Because without endothelial dysfunction, no other target organ damage can be there. That is why it has not been kept. We are basically, when we talk about any change, vascular change, it is mediated by endothelial damage. So, one target for research which is very important, and you have already had one lecture on that, how we can deliver the drugs, and all type of drugs he talked about, but I am talking about antihypertensive drugs to reduce BP variability best. What drugs we have in the market, out of them, which drug can reduce blood pressure variability very well? And here we have some data I will say, and amlodipine, because amlodipine is a widely studied drug. I don't say that the newer CCBs are not doing this, but we have data with amlodipine only, that amlodipine significantly reduces short-term blood pressure variability. So day-to-day variability can be addressed by using amlodipine. I can't claim that this is not true with other dipines, but we don't have data. Data we have with amlodipine. And you can see here that nighttime ST, daytime ST, daily ST, and ART, all the three significantly have the impact by using. And in amlodipine here was compared with indapamide and candesartan. So ARBs and diuretics and CCBs were compared, and we found it in controlling the significant reducing the blood pressure variability in comparison to ARBs and the diuretics. And best of the ARBs and diuretics were used in this comparison. treatment-induced reduction in BP variability improve outcome? Again, target for research. Does treatment-induced reduction in blood pressure variability, which I was talking about, can improve the outcome? Studies in rats showed improvement outcome related to target organ damage. That is, if we produce tipping pattern during night time, probably it has been shown in the rats. That is why I did in the human beings. Conclusive clinical studies are pending. They were pending at that time. I think now we have some studies on that. We need additional studies like average BP levels and blood pressure variability. Short or long-term blood pressure variability, which had to be taken into account. Which measure of blood pressure variability to choose? I told you so many. Relationship with physiological variables like endothelial function, which you was talking about, and the SpO2, arterial stiffness. We can have a study on the basis of that, how you can correlate them very well, and the blood pressure variability in risk stratification. As we are doing for other parameters, whether the blood pressure variability can be included for risk stratification. Those who have more variability, we can put on them and saying that they have more risk. Similarly. But overall, heart rate variability is a good thing. Blood pressure variability, excessive variability is not good. Because the heart rate variability can take care of blood pressure variability. And this is true for those persons who have transplanted heart. In transplanted heart, there is no autonomic control. Their heart rate is fixed. Are those who have pacemakers. Latest pacemakers do have that range, but the range has been fixed. Pacemakers have a fixed range. And those patients who have the transplanted heart, they are devoid of autonomic functions. And whenever the requirement is more, the heart rate cannot change. Now only blood pressure changes. That is very, very dangerous. So if you do ABPM and you find that the heart rate is not varying, the patient is at greater risk. I can tell you one example. One patient, I will not name her, she came to us when Shipra was doing her research, and the patient was referred from Cardiology to do the ABPM. And when Shipra did ABPM of that particular patient, we found that patient is having a great variability in blood pressure, but heart rate is fixed. I told to cardiologist that, sir, please call her. She is in immense danger. Triple vessel disease, type 2 diabetes, and hypertension. Cardiologist laughed on me. He said, oh, now you have become astrologer. On 7th day, the patient was rushed into the hospital, but not saved. Fixed heart rate meaning that now only blood pressure can change. Heart rate cannot change. Because of total autonomic dysfunction, you know that in autonomic dysfunction, initially what happens, preganglionic fibers are very long. So parasympathetic dysfunction occurs. And the patient has resting tachycardia. But when the sympathetic is also involved, now the patient has resting bradycardia. So if you get any patient of diabetes having resting bradycardia, this is not your case. Please refer it to higher centers. If you don't want to make a death certificate, refer it to higher centers. Because now both parasympathetic and sympathetic are gone. And his heartbeat has become the transplanted heart. Transplanted heart do not have autonomic control. So,
at what range the heart rate can vary? I mean, what is normal? So,
sir, heart rate variability is good. The heart rate varies according to need.
Okay.
If I'm talking to you, I'm shouting here, I'm
It's increase that time. I mean, if you are
any range.
yeah, I mean, how many units it can vary? I mean, that is okay.
That again depends upon the whole cardiovascular system. But safe range, if you say safe range, again here one thing is very important. Those animals we know very well, those who have less heart rate, they live very long. Turtles, they live 400 years. In Sri Lankan turtle, we have seen 400 years. And those who have very high heart rate, they die very early. Rabbit. Rats.
No, I am telling the variability is with activity. You mean to variability, or the variability even in the for say while sleeping the variability, or of course when you are doing work versus in rest there will be a variability. But what I am wondering, when you say variability, is it within the same doing the same activity the variability is also possible, or I mean what is good? I mean
Yes. In the same individual, if somebody doing a particular task have more variability of heart rate rather than blood pressure, it is good.
that is good.
If somebody is having the same activity, more variability of blood pressure and less variability of heart rate is bad.
Thank you for clarification.
Very good questions. So this particular thing, it is not confident, you have to bear in for a few minutes more. Average BP levels and blood pressure variability. Yeah.
You're saying that variability should not be.
No.
Should not be there. It's not.
No. I'm saying blood pressure variability is physiological, but within physiological limit. I was saying what he has asked very well, that for a particular task, if somebody is having more variability in heart rate, less variability in blood pressure is good. Somebody for same task having more variability in blood pressure, less in heart rate is bad. Because now heart rate cannot compensate for requirement of the circulation. Only heart is having that burden. So, which I talked about all this in association with pathological variables, and then average BP levels are blood pressure variability, both are important. Short term, long term, mainly short term blood pressure variability is more important for target organ damage. Even the long term is also, but we have more robust data for short term. Which measure of blood pressure variability to choose? Standard deviation, which has been found a better measure. And the relationship with physiological variables, endothelial function, SpO2, arterial stiffness, some correlation exists. And the blood pressure variability in this is still a question mark. That question mark you all have to remove by doing some more original research. Conclusions: is a drug-induced reduction in blood pressure variability accompanied by reduction in event rate? Is still question mark. Because we have less data. I showed you one data, but that data was very small. So we need more data to say that. Do different drug classes have a different effect on blood pressure variability and outcome? Probably CCBs and long-acting ARBs. Still question mark. But CCBs do have. Long-acting ARBs like telmisartan, olmesartan, we don't have data, but they can be used. And is there enough evidence to consider blood pressure variability as a new target for treatment? Again a question mark. We need more data, and you all will produce more data. 24-hour BP values more closely related to target organ damage and future events than office reading? We don't know that. This was the reading which we get in our laboratory. For 7-day monitoring, you see this red one is systolic blood pressure. This is Convenor analysis of BP. This red one is systolic, and this pink one is the diastolic, and blue one is heart rate. And this is the data of the patient who was having triple vessel disease. diabetes, hypertension, dyslipidemia, triple vessel disease. And you see here that his systolic blood pressure ranging in level of 180 and a lot of variability is there. But the variability in heart rate is less. This is not good. Not good. And he was, we were not able to save him. And see here, the variation index was 43%. So, these few slides are for the guidelines which have been given by Gario, by Goodstep from Japan. He is doing a lot of research on this field, and he has given the guidelines, comprehensive guidelines for Asian countries, and he has shown that the awake blood pressure, morning surge, morning blood pressure, and he has shown that diary-based definitions, best, which what he was asking, diary-based. Daytime from awakening to going to bed, diary had to be maintained. Night time from going to bed to awakening, that's night time. And morning, the 2 hours after awakening is morning. 2 hours after awakening is morning. And the 24-hour clock-based definitions, when diary time is not available, then we take this. When diary is available, then daytime is awakening to going to bed. But diary is not available, patient is not recording anything, then we rely on the time. And the time is from 9 a.m. to 10:59, 11 hours. Because we don't know at what time he's going to bed. And night time BP 1 a.m. to 6. Because we don't know, he's not keeping diary. And answer to this is actigraphy along with ABPM. You do not need no diary. Actigraphy plus ABPM can give you that answer. 3 main BP measures are calculated: ambulatory BP, 24-hour BP, daytime BP, nighttime BP, morning BP. Nocturnal BP fall, dipper, non-dipper, riser, extreme dipper, morning BP surge. These 3 have to be kept in mind. This is the guideline, the consensus guideline. All the Asian countries, specialists have gathered and they have framed it. Gario has published it in Journal of Hypertension. Then, on the basis of ABPM, we can diagnose whether the patient is having masked hypertension, sustained hypertension, normotension, or white coat effect. If the daytime BP is more than 135/85, this 135/85 is for ABPM, not for office BP. Then the high, it is considered as high and maybe masked hypertension. Similarly, office BP more than 140/90, we all know that. But for ABPM, it is 135/85. This displays better. High salt intake, alcohol, smoking, cold temperature, Asian ethnicity. You see here, the more than 135/85, which is the cutoff for the ABPM. And here you see morning hypertension. Morning hypertension. And during clinic time, it is less than 140/90. And the doctor thinks, no, it's not hypertension. But it is hypertension. And work stress, home stress, exercise, tobacco, daytime hypertension. ABPM more than 135/85. And the sleep, high salt intake, CKD, diabetes, sleep apnea, insomnia, Asian ethnicity, nocturnal hypertension. Asian ethnicity, nocturnal hypertension. So for Asian countries, we have to concentrate more on night blood pressure. Opposite to what physicians are doing. I am very perturbed that in medical practice, the things which are being done are exactly opposite. Most of the time, we are behaving like fire extinguishers. We are not thinking about prevention. And see here, the night-time dipping, blood pressure, if the salt is more, salt sensitivity is more, CKD, CHF, diabetes, structural vascular disease, insomnia. These are the factors which have to be kept in mind when the patient is having night-time dipping, and that dipping pattern can be changed because of that. Night-time surge, again you go for OSA, arousal, REM sleep, nocturia. And that will define whether the patient is having basal BP, extreme dippers, non-dippers, and risers. That will depend upon that. These are the guidelines I told you, prepared by KU, Asian country data. And morning surge, again we know the cold conditions, exercise, work site stress, smoking, alcohol, insomnia, sleep apnea, person taking alcohol during dinner time. Patient will have more surge on that particular day. We have examples. The persons have taken good dinner, good alcohol. In the morning, death bed syndrome. Gone. And where we do this is new hemodynamic biomarker initiated anticipation medicine. This is a very new thing. Only Cario has prepared data for that. And here you can see the sensitivity analysis and waveform analysis, and it is totally dependent upon actigraphy and the ABPM homework. On the basis of that, he was able to do the, including all these, he was able to do the variability analysis, including the morning surge and the disrupted circadian blood pressure variability, and morning BP surge, day by day morning BP variability. So on the basis of that, winter risk, you can see here, and all these things taken into account, new hemodynamic biomarker initiated anticipation medicine. On the basis of that, one can predict, and this is very important nowadays. You might have already seen in newspapers and the media that particular celebrities are gone, young age, doing a lot of exercise, and they are no more. So this can help them. And again, active sensitivity and thermosensitivity can be kept in the loop. And in the winters, this was done, and they have find out that hyperthermosensitivity and the negative active sensitivity can be responsible for the increase or decrease range. So now we have produced in our laboratory on the basis of that what I was talking about, and this was the studies in management of hypertension. We did continued 7-day, 24-hour monitoring required in messer hypertension and other DVTs. So what we did, we collected data from health and disease, 7-day, 24-hour ABPM was done in the patients, and the patient was recruited basically from the cardiology, neurology, and the controls were taken from our students. And then it was found that here we can see the diagnosis of systolic chat in 3 profiles, and one occasion of complicating diastolic chat, and one still another occasion of systolic messer hypertension was made on the basis of chronological interpretation of circadian rhythm. You may be thinking that what is this messer? This is the terminology of the chronobiology. Messer means mid-estimation of the statistics of rhythm. So this statistics is not the same, it's not arithmetic. And chat is circadian hyperamplitude tension. And at present, the lot of physicians and lot of clinicians do not believe on this theory of chat, originally given by Helberg. And in chat, he said that chat is circadian hyperamplitude tension. I agree. At present, this is not being practiced, and most of the निकाल दिया सर, तोड़ दिया
Sir, what was the median age in your group and in study?
I said that this study was my PhD thesis, and it was including all persons with health and disease. We compare in the same age group.
सर ये ओपीडी पेशेंट की है या
IPD. और उस सब at that particular time it was very difficult. Machines were very expensive, and I was afraid that the patient will run away with machine. I still remember one patient. He was a Nawab. He said, I explained him everything, that you have to wear this machine for 7 days. At the time of going to washroom, you have to open it and then wear again. And I told him, explained him that how it had to be done. And I explained him that if you have any difficulty, call me. I gave my number. 6 days passed, and Nawab Sahab never came. My compounder said, sir, this time you are wrong. He has gone to Pakistan. Actually, he was living in both countries. But to my surprise, on our 8th day, Nawab Sahab appeared. I said, sir, you are so intelligent. You never called me for a single time. You was able to wear it again and again. He said, no, doc. It was just a matter of 7 days. I never took any bath. So it is possible in my country only. It is possible in my country only. That if I say that patient to wear this for 1 month, 3 months, he will wear it. And may not take bath for 3 months. Because Harmida told me in that meeting which I was talking to Antalya, he told me how it is possible to do it for 7 days. In my country, after 48 hours, the patient will come with a pistol. Doc, remove this, I will shoot you. But this is possible in my country. That is why I am inviting you all to do some basic research and produce some Indian data that are very much required. What you have learned with the courtesy of Professor Vinod Kumar, you can do a lot of human research.
So not only patient, normal individual or also agree to wear 7 days.
Yeah,
Yeah,
they are ready,
data.
still ready. And I myself weared it 5 times.
Yeah, 7
And-
days, even 14 days. They
And my sister-in-law sitting here, she wears for 10 times. And one time I was wearing that, and Prime Minister came, I was invited, and I had to go through a lot of searches that what you are doing all this. They were very scared. What he is wearing. So, but still it is possible. And so this was done, and then other groups have the functional arterial stiffness, the correlation between pulse volume and age in apparently healthy subjects, that was published, and the circadian pattern of blood pressure in normal pregnancy and preeclampsia, that was published in Journal of Obstetrics and Gynecology. Well, what we did in this, for preeclampsia, we did ABPM in first trimester of pregnancy, and we were able to predict that how many of them will develop into the preeclampsia. So I mean to say that by ABPM, we were able to predict that which lady is going to develop preeclampsia. And the basic thing, what I can say you, being a physiologist, that if you know the basal level of blood pressure of a lady and she becomes pregnant, in first trimester blood pressure should not rise, should fall because of physiological reasons. And if it's not falling, then probably lady is leading to preeclampsia. You all know that preeclampsia and eclampsia do not have any proper treatment. If we can know prior that that lady is going to develop, then we can do a lot. So that was published. It was an MD thesis in a Queen Mary under Shipra Bhardwaj, and hypertension screening of women as a community-based approach, comparison based on age group, October 2000, Journal of Hypertension published, and statin-induced mitochondrial dysfunction and targeting coenzyme therapy. It was published in World Heart Journal. It was not done in my lab, but it belongs to me. And then we did this again a PhD thesis, Nursing Rotating Night Shift Work Study. Nurses were recruited, they were having shift study, and conclusions here the 24-hour chronomics of BP heart rate was done in the terms of double amplitude, acrophase and hyperbaric index, and we found that reverse pattern of acrophase and HBI of blood pressure and heart rate along with salivary cortisol during night shift represent desynchronization was found and was confirmed by doing the cortisol and even the melatonin. And recovery occurs during day shift. That was also shown by showing our data. Then we did studies for studies we did influence of melatonin on circadian pattern of blood pressure and autonomic regulation of cardiovascular system with coronary artery disease. This study was done as a PhD thesis of Dr. Shipra Bhardwaj, and she did this work in relation to the Lari cardiology. Professor V.S. Narayan was the head of department at that time, and most of our ABPM data was done on these patients of CAD, and one data I showed you, Mr. Nihotri, was belong to the impact. And these were the objectives, and what we found that CAD subjects with hypertension, here the melatonin was given. 5 milligram melatonin was given in the evening. And at that time, 5 milligram melatonin was not available in my country. The pharma people were having melatonin plus etitolam. They were not having single melatonin tablet. So what I did, I purchased melatonin powder and asked a company to make tablets. And I said that I'm going to purchase all your tablets, 5,000 tablets. Then he said, no, minimum 10,000 tablets. Then the study was done. It was funded by ICMR. And then we had this chat study. In chat, again published data, we were able to show that chat can be reversed by changing the dosing pattern. If the patient is having 4 drugs and he's having chat, and what we do, just adjusting the doses of drug in the morning, evening, the chat can be reversed. That was shown in this particular study. Then again, this study was funded by the DST, and in this study again, Shipra was the main author. He did all this work, and Professor M.L.B. Bhatt was the Vice Chancellor of this institute before present Vice Chancellor. He was also one of the guide. And here the chronobiological assessment as an early predictor of chemotherapy induced cardiotoxicity in breast cancer. That was a funded study done here on the basis of ABPM and cortisol levels and melatonin. We were able to predict that these patients are going to develop cardiotoxicity. Please reduce the doses of anti-cancer drugs. Before that, these patients used to suffer a lot because when the cardiac symptoms appear, then only the radiotherapist referred them to Lari cardiology, and it was very late when the doses were reduced. So that was the implication we had. That was published in Journal of Hypertension. Then we had the studies in the management of hypertension, not very important, as a switchover. And again, one study was done in variation of circadian pattern of blood pressure and cardiovascular autonomic regulation in premenopausal women and postmenopausal women with relation to gonadal hormonal profile and melatonin. This was done again by Shipra Bhardwaj, again funded by ICMR. So what message we have for the social media, or you can say the persons as a large that rise with sun, just with sun. Our studies showed this. And working hours management is very much required. If you are not a shift worker, don't behave like shift worker. Avoid late night working. 10 to 12 hours of light is best and enough time for activity working. So don't become nocturnal unnecessarily. So, and developing a good sleeping environment, we had a lot of lectures on this and very good information shared by our esteemed faculty on removing distractions like TV, laptop, mobiles during sleep. Keep sleep in place dark, not too warm. All these things have already been told very well by our esteemed faculty. Most of them are limiting stimulation before bed already have been discussed. So source of significance choosing the chrono diet, what we promote for metabolic circadian rhythm maintenance and regulation. Thank you. Thank you very much.
Sir, Chrono Pagoda is making.
Any questions after Pagoda?
No questions.
Time for Pagoda.
No questions for the convener. They can ask you, I'm going to be available.
Fine. I'm available here.
Should
can
have
ask me
tea
later.
and have valid appreciation.
Fine.
If you agree.
Yes? Done?
बाद में पूछ लीजिए मैडम बाद में पूछ लीजिएगा अवेलेबल है अरे कुछ तो कंसेशन देंगे
We have had some happy moments, some glitches with some stuff that are there, but I hope you were ignoring all our, what do you say, whenever we were falling back, you held us. All the participants have been really enthusiastic through these sessions. And I welcome you all to the valedictory session now. In this program, we had two nothing is possible without a very actively working member of organizing team. So there were so many people running around. So we would like to thank Dr. Abhinav Verma, member of organizing team in School of Chronobiology. Is he around?
No, it's not.
Still running
Absence
around.
here.
Dr. Vandana Avasti. Dr. Sajid Ansari. Dr. Shipra Bhardwaj. Dr. Ajay Tiwari. Professor Anuj Maheshwari.
वहाँ ले लीजिए हो गया बाद में खींच के हम लोग ड्राफ्ट कर लेंगे
And now for the awards. Well, there are two awards. We have one Best Presentation Award and one Best Student Award. So the Best Presentation Award is presented to Dr. Ritu Tiwari from King George's Medical.
बीच में आने दीजिए she presented well this is the average of the judges who scored
We have no.
so now you have to judge whether it was real or not
Proceed.
Togetherness is coming to an end. First time in my life, 7-day conference. We have done 4 days, 5 days, but 7 days. It's too much. Because from last 7 days we just down. No patience. Possibly. Anyway, so we had a very good time together, and we had excellent faculty. I have no words for the words of praise for Professor Vinod Kumar. Choosing this excellent faculty, I again say that I cannot ask more. They have done excellently well and given me a lot of food of thought that what we can do. Now I think that if this particular thing would have happened 10 years before, I would have done a lot. Now it is my last 2 years in the tenure, but it does not matter. even after my retirement, the Chronomedicine lab will survive. It will remain either at my house or at KGMU, it will be there. So thank you all for joining us. Thank you very much. And for all the faculty coming from abroad, sparing their valuable time of 7-8 days to this country, we are grateful to you all. Thank you very much.
Well, it can happen. You need a tryptophan to form the melatonin. So as you need Professor Verma to organize anything in Lucknow. This is our first joint venture, and I hope it has done well. From my side, I am fully satisfied, and I give whole credit not to Professor Verma, but to Mrs. Verma. I think she deserves our appreciation. Freeing him for all 7 days, joining us over dinner, staying up late, listening to all our bullshit during the evening very quietly, and I hope not complaining too much, Professor Verma. What kind of people are these? This was a very relaxing time for our students, really harder than this. But beyond we two, Professor Verma and I, Aakansha did a lot of work behind the scene. So I think she deserves all credit for organizing it. She has another piece told her that if you cannot say anything to Professor Verma, try to say to Shipra and then communicate through Shipra, and I know it will be done. And it has come out so well, Professor Verma. Lot of thoughts, as you say, a lot of things, and there is one more thing, and it's premature, but Professor Verma has agreed to organize another at least 3.5-day meeting. Half I say inauguration, it will be only in the evening, and therefore 3 days meeting somewhere the last days of January or first week of February, but most likely 28, 29, 30th of January. We'll have to see this Sunday so that people traveling from abroad have their weekends either before or after, so that it's more convenient. Friday travel is expensive, so they should arrive here somewhere in the middle of the week, because Friday travel is really expensive in terms of, those dates are going to come up very soon. I'm going to advertise this in Istanbul on 30th, 31st of March. I'm sure committee will agree. This is turn of India. So be prepared. In theory it will be Asian sleep research and Asian chronobiology, but I will definitely invite all colleagues right from South Pole to North Pole, selected ones. I never invite we want 20 good people rather than having 100 people for anything else. So you have been very good as participants. You cooperated well. Even the doctors stayed. Yesterday when I said I will not let you go out, even Dr. Salmi Srivastava stayed half of the lecture, half through the lecture. And both societies are open. So if any one of you want to organize anything in India, 1 day, half day, for students, for school children, let us know. Both Indian Society for Chronobiology and Indian Society of Chronomedicine will help you academically, financially, because our only aim is to reach as many people as possible, as many corners of country as possible. We go, you won't imagine, we went to Uttarakhand, Nakhal, after arduous journey to talk to a bunch of high school children, and we got reimbursed our money from Indian National Science Academy, but after 3 months, after a lot of auditing and other things. but both Professor Meva Singh, I went over there, he stayed there 3 days, lectured to their students. So we also have a program of Indian National Science Academy once for remote areas. So 23, if you want to do, if you have any your village or any, wherever you in the country you live, let me know. As a fellow of National Academy, I can organize that. You don't have to pay anything to us. We just simply love to go. We will try to spend little our own money if we can really contribute in some way to you people. We are always available for advice. Please do write to foreign faculty. Their emails are there. Nowadays you can search anybody, anywhere, right? And you be in contact, and we would be very happy as a organizer if some of you start adopting chronobiological procedure, methods, concept in your own daily life, surrounding, teaching to your neighbor what is sleep hygiene. Don't go and you have to imagine who have the sleep problems. Only you can go and advise. So with all these words, I think we are going to meet again in banquet, Professor Verma. So I'm requesting him to make final announcement and close the ceremony of valediction. Professor Verma, please.
So before I end, Professor Vinod Kumar has thanked everyone. 2 more persons have done a lot in backhand. One is Shipra Bhardwaj. He has done all the work which was required for the conference. So he must be thanked. And Dr. Shipra Bhardwaj. He was not just attending, he also did a lot of work which was required, and he must thank both of them. And not only this conference, whatever I do from last so many years, this team is same. Which one I organized, the team remains same. And now we have added in Aakansha another person in the team. So we have very good team to organize anything. Today, banquet will be at Hotel Gemini at Hazratganj. For faculty, we have arranged transport. At near to Parivartan Chowk, Hotel Gemini. Good hotel. It will be, of course, before that, some CME will be there. In India, the science is living on the mercy of the CMEs because we don't have any government money. So what we organize is being funded by the industry. So they almost require something from back home. So in that banquet, you all are invited. We have made transport arrangements to our faculty and to some outside participants, and rest can join if they wish by arranging their own transport. So all of you are invited at Hotel Gemini for banquet dinner. Thank you.